All right. Hello. 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 I'm Dr. Ila Dayananda. I'm the medical director at Oola, and I'm thrilled to welcome you all to the Planning for Pregnancy event. Looks like we have a pretty good turnout, so welcome all. This event is co-hosted by Oola and Parentcraft. So today we're going to go through some introductions, and we're going to give you some key points to know about trying to get pregnant, what to know before you try, as you try, and the pregnancy journey, what to know about pregnancy once you are pregnant. Now what? We will have a live Q&A at the end of the session. Please feel free to drop your questions into the chat box, and we'll get to as many of them as possible at the end. So let's kick it off with some introductions. We have three panelists today. Hello again. I am Dr. Ila Dayananda. I'm an OBGYN and the medical director at Oola. I'll pass it over to Casey.
Going to unmute myself. Unmuting, step one. Hi, everybody. My name is Casey. I am a certified nurse midwife and a mom of three daughters, including a pair of identical twins. And I'm the founder of Parentcraft. Parentcraft is a midwifery guided educational space that offers private and group classes from preconception through the labor and birth journey into the postpartum and new parent domain. And I always refer to Parentcraft as my fourth and final baby because it's such a passion project of mine to talk with people about the midwifery model of care and to bring more understanding about the normal physiologic birth process to expectant families in New York City and now virtually around the country. So I'm super excited to be here and to jump into talking about planning for pregnancy. So thanks for having me.
And hi, everybody. My name's Katie Sigler. I'm also a certified nurse midwife, and I am a midwife at Oula.
All right. Well, I am thrilled to have the opportunity to share with you more about Oola. I'm going to start by saying Oola is here to set a new standard for pregnancy care. The care at Oola is really based on a collaborative model. And to me, there's sort of three components of that. The first you've heard about here a little bit is our tight collaboration between our midwifery team and our OB team. At Oola, we firmly believe that midwives are the experts in physiologic birth. The OB team is there to support our midwives and to provide supplemental care and surgical care as needed along the way. This collaboration allows for ongoing care throughout the entire pregnancy journey. The second piece, and the most important, is centering the patient. The collaboration between the patient and the medical team. Unfortunately, I'm also a mother of two, and I've had my own pregnancy journeys. And even as an OBGYN, armed with so much information, I had a pretty disappointing experience. And we feel like we can do much better. And the cornerstone of that is really centering the care and the pregnancy experience around what the patient needs. At Oola, we are designing technology as well as modalities to interact collaboratively in an ongoing process throughout the pregnancy journey and to center the patient's needs by involving them. This is radical now, by involving them in their decision making process. Patients should be guiding their decision making about their health and well being. And that's really the core of the collaborative experience that we're trying to design here. So, how do we get there? I mentioned technology. Technology is a big part of what Oola can offer. We have an amazing patient portal, and this patient portal allows for asynchronous messaging, which means ongoing messaging throughout the pregnancy experience. We are offering in-person as well as virtual appointments. And here again, it's really up to what fits best for the patient, but we have a variety of modalities. And this allows for virtual coaching along the entire pregnancy journey. Another piece of the collaborative experience is creating a care team around the patient with the patient in the center. So, of course, yes, you need your medical sort of experts in terms of the delivery and the prenatal care. But it's not just that. There's a holistic approach to pregnancy that involves so much more, as any of us out there that have been involved in pregnancy know. So we're talking about definitely engaging with doulas, nutritionists, lactation experts, pelvic floor therapists, et cetera, to build care around the patient based on what they tell us their needs are. And again, the technology is so important if patients choose to use it in order to put together an experience that is a two-way information flow, which in my opinion is just not something that's part of the traditional medical system. And I want to say one of the best parts of all of this is that we will be in network with all major insurance companies, including Medicaid. Again, I just want to summarize and not take up too much time here because I'll tell you a lot more about Oola later on as well. We are just really here to look at pregnancy differently, to set a new standard. It's really about time we do that. And I'd like to say that we promise to lead with evidence, and we trust our birthing people to know themselves the best along the way. So that's Oola 101 to start. And I'm going to pass it over to Casey now to please tell us a little bit more about Parent Craft.
Great. So I already introduced a little bit about what I do through ParentCraft in terms of group classes and private classes that we offer. But I think one of the things that has been that has really brought us close together with Oola in conversation about how we approach the idea of a patient-centered birth. One of the things we can offer at ParentCraft that has been really fulfilling for both educators and students is to work with people who have chosen to give birth across different locations in the New York City birth landscape. And I think what we're going to be talking about today is about unpacking like what are the right questions to be asking yourself to make that informed decision. And I'm super excited to talk with everybody today about how Oola plans to offer education in that space. And to help people to find out, is Oola the right fit for me, and what are the other choices that are out there. So often we think about childbirth education as a traditional kind of like, okay, it's your third trimester, this baby's coming out, you got to go learn about it. And then when you go to that class, you think, I'm not even in the right birth location, so how can we start this educational process earlier for people is something that we feel really passionate about at ParentCraft, and are working on in the community. So anyway, we offer classes based out of Park Slope, but we're now virtually thanks to COVID, anywhere, which is kind of interesting and fun. So that's a little bit more about me, but you'll hear more from me later too.
All right. I'm going to pass it over to Katie now to tell us a little bit more about before you start trying, please.
Yeah, so as Casey said, the midwifery model of care really takes a global approach to healthcare. So it really should not be a big surprise that Oula's intention for preconception care and counseling really considers the whole person. Planning for pregnancy is an opportunity to take a radical approach to self-care. And I find that families find that pregnancy or even the idea of pregnancy can be a great motivator to really optimize healthy eating habits or form a regular exercise routine. I never like to think of BMI as like an end all be all indicator of health, but the research does show us that birthing people at or below the low end of the normal BMI range or at or above the high end of the normal range can have trouble conceiving. So BMI is certainly something that we have to think about. But it's important to think about toxic habits too. If you smoke, now is the time to quit. If you use alcohol to help you manage stress, now is the time to think about some alternate coping strategies. But I like to think of preconception as an opportunity to think about your body in a different way. In the preconception period, just some like brass tacks, we recommend that you start a prenatal vitamin or at least a daily folic acid or folate supplement. It's always good, first and foremost, to get your nutrients from food, but prenatal vitamins are designed to ensure that you get the extra folate, the extra iron, calcium, and other nutrients that the pregnant body and the growing fetus demands. But not everybody tolerates supplements in the same way. When I was pregnant, I could not handle the type of iron that was in typical prenatal vitamins. It caused me terrible GI issues. So I figured out a workaround by taking a multivitamin that didn't have iron in it. I took a separate folic acid supplement, and then I took a liquid plant-based iron that was easier on the GI system. Another example is that about a third of people have a gene variant, which means that the body can't metabolize folic acid. Folic acid is like a very sort of common shelf-stable form of that micronutrient. And we want you to have extra folic acid in the preconception and early gestational period because it helps to optimize the development of the fetal neural tube, which is like heart, brain, spine of the baby. But some people, because they have that gene variant, might need to take an alternate form called methylated folate instead. The point here is that not all supplements are created equal, and not all people respond the same way to the same supplement. So we might need to do some research or experimentation before we find the supplements that are right for you. All in all, it's important to think about small tweaks that you can make in your routine or in your home to optimize your health. You want to avoid plastic food and beverage containers because the chemicals that they leach into what you consume can act as endocrine mimics, which can confuse your body's hormonal regulation systems. Think about your home cleaning products or your beauty products, and definitely keep up your preventative health care. You want to include regular visits to the dentist for cleanings as well. So planning for pregnancy is an amazing opportunity to learn about your own body. Ovulation used to be something that birthing people tracked on paper flow charts, but now we can do it on our phones. But the focus here needs to be on an opportunity to tune into yourself and to your cycles. It might take months of tracking for you to start to see the patterns that are normal for you, and that's totally okay. It's important to see this process as information gathering and focus on learning about yourself without judgment. You don't want to compare yourself to the woman down the hall, the people down the street. Everybody's different. Birthing people who have known endocrine disorders like PCOS or thyroid issues, people who know that they live with gynecologic issues like endometriosis or structural abnormalities like uterine polyps, you can do some work to mitigate these issues with lifestyle changes, but you're probably going to have to manage those concerns with medication or other interventions prior to conceiving. But information is power, and we want you to feel like you understand your body as you approach pregnancy. I always think it's important in the preconception period to think about your benefits. Pregnancy and birth are often the first time that young, healthy people even need to go to a hospital in their life. So pre-pregnancy is a great time to think about how your employment benefit needs might change as you build your family. If you're planning a pregnancy anytime in 2021, right now is the optimal time to think about this because employer and government-sponsored health benefit plans are in their annual open enrollment period, which for most people lasts until about the middle of December. And outside of changing jobs or other life events, this might be the only time of year that you can make the changes to opt in or opt out of a health or other benefit plan. Most notably, if you're thinking about pregnancy and you're in a high deductible plan, you might want to consider switching out of it prior to pregnancy because in a high deductible plan, you have to pay everything up front until you max out that deductible. And in the course of a pregnancy, you're going to get there. So you want to think about those kinds of issues so you don't have to pay such a significant amount out of pocket before your plan coverage kicks in. And you should also be aware that while prenatal leave benefits have improved over the last couple of years, sadly, you should not expect to receive your full pay while you're out on parental leave. So planning for pregnancy also requires some thoughtful financial planning. You want to take this opportunity to learn about what your health plan covers, what you might expect to pay out of pocket for healthcare in pregnancy, and what you can expect in terms of paid family leave. So I want to talk a little bit about the visits that Oula is launching today. One category of visit is called a preconception coaching visit. And then we also have an early pregnancy visit that Ila is going to talk about in a little while. But at Oula, we're offering these one-on-one virtual coaching visits to help you really think through and manage preconception. The visit is an opportunity for you to sit with a midwife and talk through the details of your life that might affect your fertility, things like your medical history, the medications you take, your social circumstances, your support structures. It's really a chance for us to target our teaching on topics like ovulation tracking or lifestyle changes to your particular needs and experiences. It's a chance for you to get to know us as a potential birth team, and it's a chance for us to get to know you. And if your visit uncovers some issues that might need follow up, we can certainly manage the relevant specialist referrals to ensure that you get the care that you need. So who might consider a preconception visit? Certainly, I would argue that everybody needs one, and it could be useful to anybody, but we particularly encourage any birthing person who has a complex medical or medication history, or anyone who's considering a first pregnancy to schedule this preconception coaching visit. We've really designed it to be a balance between conversations about your health that can feel more clinical, but also with lots of time focused on your particular educational and emotional needs. We want you to walk away from the visit with a better understanding of your own health and a better understanding of the pre-pregnancy period in general, so that you can feel empowered and educated as you plan to expand your family. So now I'm going to hand it back over to Ila, who's going to talk a little bit more about what can be either the easiest or the hardest part, the most fun or the most stressful time, which is trying to get pregnant. And I'll be back in our Q&A session. So if you have any questions and any questions that are particular to me, please put them in the chat and we'll get to them later. So Ila, all you.
Thank you, Katie. So I have to echo what you just said at the end there. I reflecting on my own experiences trying to get pregnant, and I think it was a whole host of emotions from excitement to impatience to um, just nerve wracking. Why isn't this working? Things just don't always go the way that you think they're going to go. And even as an OB armed with a lot of info, there's a lot of learning that I had to do about myself and my body and trying to get pregnant. And there are a lot of myths out there. There's a lot of information out there. A lot of the questions that we often get have to do around age, for example. I've often heard, hey, I'm 35, I'm 40. Is IVF the only option for me now? I don't know if I'm going to be able to get pregnant. I think many of us have that story about a friend who went off birth control and was pregnant right away, but it's been like 4, 5, 6 months for me. And what does that mean? And for those folks that are looking to pursue either penile vaginal sex or IUI, how do you time all of that? Is there a particular time that would actually maximize the chance of the egg and the sperm meeting and getting pregnant? So a lot of questions come up, and I'm going to take just a few next minutes to go through some of the high level. I want to really start by highlighting that this is a fact. We've just gone through some myths, but this is a fact. Trying to conceive looks different for each person. And it's just really important. It's sort of a cornerstone of going on into this pregnancy journey and the preconception journey is just to remember that really getting pregnant looks different for each person. And, this is a great space to connect with your healthcare provider, try a preconception visit, such as the one we're offering at Oola, to understand your body, understand what you're desiring, and what you want your journey to look like so that you can start really formulating that from the get-go. Another fact that I think is very important for us to center around is that there are also many ways to make a baby, many, many ways to make a baby. And I'm going to move forward into talking a little bit more about understanding your body and the fertile window. So some of this is going to have to do with cycles and will be a little more pertinent to people who are uterine bodied. So again, we all have had that experience or have a friend, or in my case, a lot of folks that come in and say, I've been trying for 2 months and nothing's happening. And I just think something's wrong with me. So, on average, it actually takes about 6 months of active trying to get pregnant. And what does active trying mean? I'll go into that in just a second. But if you're looking at penile vaginal sex or IUI, there is sort of a window that we call the fertile window as to when you have the most success to conceive of a sperm and egg or to meet. And even if you're timing all of that super, super well and following your cycles and doing all of the work that it takes to get very detailed about these things, you actually have about a 30% chance of getting pregnant in one cycle. So it is actually normal. It's part of the bell curve for it to take about 6 months of active trying if you're of average age, health, and fertility. Katie mentioned this before, which is to getting to know your body. Get to know your body. If you are on birth control and you're uterine bodied, it's often advisable to get off birth control for a couple months before you start trying to figure out how to time things, because this can actually help you get to know your body and your natural cycles a little bit better. And then Katie also went to this a bit, but I want to stress it here again, lifestyle factors. Again, this is the time just to get to know yourself, to optimize your mental, emotional, your physical health. lifestyle factors like stress and sleep and diet and exercise, putting together modalities that will help you alleviate stress, get some sleep, get some whole foods in there, and ongoing exercise. But by all means, this is not the time where you need to go start running marathons or, a lot of folks that come through are very stressed about stress. And, it's a time to actually just take a deep breath, get to know yourself a little bit better, and do things that optimize your health in the best way that you possibly can. So let's go back to that fertile window because we get a lot of questions about this. Again, for folks that are looking at penile vaginal sex or IUI, you want the sperm and the egg to meet. So we're centering this conversation around ovulation. And just a reminder, ovulation is when the egg is released from the ovary and is traveling down the fallopian tubes. And in order for the egg and sperm to meet, the timing, the fertile window, is really about 2 to 5 days before ovulation and 1 day after. So we'll talk about this in a second. If you're somebody that feels like they would like to get to know their bodies a little bit better and really work on timing and understanding when this fertile window happens, there are ways to do that, which is the great news. But for many of us, we're very busy. And if you're looking at penile vaginal sex in particular, one way to really maximize your chance of having their sperm and egg meet during this fertile window period is our tip down here at the bottom of the slide. If possible, have sex every 2 to 3 days, starting a week after your period starts. So that's a tip to sort of put in the back of your head in order to make sure that you're maximizing the egg and the sperm meeting during this time. For those folks that are uterine bodied that are open to getting to know their body a little bit better and want to understand exactly when that fertile window is happening, there are some aspects of your menstrual cycle that you can track. Katie said before, I actually still kind of use a calendar, so I might be dating myself. But if you're tech savvy, there are many apps that you can use. We'll go into that in a second to look at the length of your cycle and sort of track what's happening. Um, Cervical mucus is a huge indicator of ovulation, and we'll talk about that as well. And then the other piece is understanding when you're going to ovulate based on other factors that your body gives you clues. We'll go on to the next slide, but there's some really interesting clues. Many people have sort of a sensation or some cramping or a feeling at the time of ovulation. And again, uterine body people, birthing people, and your body is the best. You might have other clues past sort of this just general science that tell you that you're ovulating, and you know that from just knowing your body. So keep track of those things because they'll come in handy if you're trying to time the meeting of the sperm and the egg. So in terms of more uh, marketed and tech savvy options, there's a period tracker. There are many, many, many on the market, like Clue or Spot On, where you can understand when you have your periods, what your cycles look like, track symptoms along the way, and just sort of get to know your body in a way where everything's stored in one place. Body temperature is another way. Your body temperature changes based on the hormones that are released throughout your entire cycle. So there are many different avenues to checking your body temperature, orally, vaginally, underarm. That could be work for you as well. And then actual ovulation monitoring. So again, ovulation, when the egg is released from the ovary, that's the time where we want sperm to sort of be ready and waiting to meet the egg. And ovulation predictor kits. These are simple urine pee sticks, basically, that you can get over the counter. What they do is they allow you to know if a hormone called luteinizing hormone is released, and this hormone is released right around the time of ovulation. So you might often see, it's like a LH predictor kit, or that might be a terminology that you see. And then actually my personal favorite, because two things, it's free and you get to know your body a lot better, is checking your cervical mucus. Your cervical mucus is often sort of dry, but around the time of ovulation, it gets more clear, more thin, more slippery. Kind of think of it as it's thinning out so the sperm can swim through, so to speak. And if you're noticing that that is what you're seeing with your cervical mucus, you're checking it between your thumb and your forefinger, you can see a change in consistency. And when you see this sort of thin, slippery cervical mucus, you know that you're entering that fertile period, and it's a time that can maximize your chance of sperm and egg meeting. So you've been trying all of these things, and you're still in a space where things are just not working the way you thought they would, or you just have more questions, or you're concerned. There are times where it makes sense to reach out to get more information, to get more support, and reach out to a fertility specialist. Age comes up quite a bit. It is true that fertility declines with age for people that are uterine bodied, and actually for people that are penile bodied as well. If you're uterine bodied and you've been trying to get pregnant, and when I say trying, pertains to active trying for a year and you're less than 35, or for 6 months or so and you're greater than 35, it's a good time to check in with a fertility specialist to get more information. If you're over 40, again, this doesn't mean that if you're over 40, you can't get pregnant or you have to go to IVF, but when you're over 40, you might want more tips and tricks to really maximize your chances of getting pregnant because your fertility is a little bit lower. If you aren't ovulating, so what are some signs of that? If your cycles aren't regular, if you're not having withdrawal bleeds or periods, then it's a good time to check in also with your fertility specialist. And if you live with a gynecological health or a hormone condition, such as PCOS, endometriosis, these are conditions that are known to possibly affect fertility. So it's a good time to check in. If you are penile bodied and you're over the age of 50, this is also a great time to check in. There are a lot of sperm analysis kits that you can even do at home these days. But there are ways to check in just to get more support and more information along the pregnancy journey and the trying journey. So let's say you've done all these things and you find that you're in a space that you have a pregnancy, you're excited, you've been trying, you desire this pregnancy, and so now you're in the space of I'm pregnant. Now what? And we're going to go into a little review of early prenatal care. I'll pass this back over to Casey to give us some more information.
Thank you. So this is a little map to kind of understand, what typically happens during a first trimester of pregnancy. And I think what there's a real gap in care here for people, which is that, you might pee on a stick somewhere around 3 to 4 weeks after your last period. And then you reach out to a care provider. You might not even already have a care provider. So you might be literally just Googling care providers. And then you might not get an appointment with that provider until typically 7 to 10 weeks is kind of when it's recommended to come in person for your first prenatal visit. And so those weeks that stretch into months in that first trimester are a super vulnerable space for pregnant people, whether it was a planned pregnancy or a surprise pregnancy. You go through a huge emotional turmoil of feeling uncertainty, changes in your body. You feel anxiety. You, of course, feel the very real fear of miscarriage and concern around that. And I think what ends up happening is that we end up isolating ourselves. We become more removed from the support systems that we have, and at a time when we deeply need that support to go deeper. And so I'm really excited about the early coaching that Oola is going to be offering, because I think this is something. It's a space where midwives thrive. The educational space, the reassurance of what is normal in terms of expectations around symptoms and changes in the first trimester, and it's the beginning of building trust. And when we talk about building a satisfying birth experience for people, there's an interesting survey called the Listening to Mother survey where they talk about what makes for a satisfying birth, and feeling heard by your care provider and included in your care is really at the core of that. And so I think that this is a great opportunity to start building that trust, um, as you go through that vulnerable space, not really knowing. And it's the beginning of not knowing what the heck is going to happen, which is the theme for the rest of pregnancy, into birth and into parenthood, as I'm still learning now with my 8 and 6 year olds. Um, okay, so at the first prenatal visit, it's actually a great opportunity to kind of, we think of it as sometimes it's kind of like a blind date. It may be someone you've never met before, right? You need to share a little bit about you, and you also want to hear from your care provider, ideally. And so this is an opportunity to really spend some time talking through your health history. Katie went over some of this a little bit earlier, but it's an opportunity to kind of tell your story. Your health history is kind of the story of your body, the wisdom that you bring to this moment of being pregnant, and being present in that visit and in that space. And So, it's so fascinating when we really do a deep, thorough history with a patient. We're able to uncover things that are even surprising to the patient sometimes. Like, I had no idea that story, would be relevant to my pregnancy journey. And so having that space and time to do that is so essential at the first visit. And something that we midwives have always advocated for more time with the provider, to allow for more time where you have your clothes on and you're actually talking, because the physical exam is actually a really small part of what we do during that visit. But this slide shows all of the many physical components that make up a primary prenatal visit. It is totally comprehensive in that way. We can, as midwives, we provide full scope women's healthcare. So we can do a pap smear if it's appropriate. We can talk about health promotion aspects. And we also will offer you routine blood work specific to being pregnant, and we can offer ultrasound confirmation of a pregnancy if that's something that you choose to do. That's an optional component of a first prenatal visit. So I think having information in advance about what to expect, then you can the testing that you can opt into or opt out of, that can be a helpful tool to sort of tap into that in your decision making process. So you're pregnant and you're still pregnant. You go to your first visit and and you start to kind of settle into the reality that, hey, this is sticking around and I'm actually, moving through this space. We say it kind of, it takes 9 months to really get ready, and prepare. But a lot of that preparation and kind of in terms of your thinking, if you can plan ahead, not that you need to make your pregnancy longer than it already is, but that you can kind of plan ahead to start to think about, like, where might I want to give birth? I think that it is a privilege to have access to education and around choice, and we have an issue with accessibility and equity in New York City. And I'm excited to hear about. We're going to talk more about how Oula is going to be working with insurance and specifically Medicaid later in the Q&A. But I'm excited to see more options coming to the New York City birth landscape. As a midwife, I moved to New York City in 2005 to pursue midwifery, and I've seen 3 in-hospital birthing centers closed during that time. It's pretty ridiculous at this point, that we are New York City where anything is possible, and yet we cannot really build and sustain birthing center options for expectant families in New York City. So I am pro-choices here. I think that we need to bring midwifery to the forefront in all of these settings. And I think that the hospital birth has become the default for all of our patients, and that's the foundation of public health in New York City. That could change. At Bellevue, they had an in-hospital birth center there that was Medicaid. That's the gold standard. That was the gold standard for the country. So it's pretty exciting to think about that from a birth equity lens moving forward in the landscape in New York City, and Oola leading that way is really exciting. So you might kind of have an idea of where you want to give birth, or maybe you've never thought about it before, and doing a little bit more research about some of the factors that would affect your decision. You can then bring that to a partner. You can talk about that with your provider at that first visit and start to talk about, like, is this going to be the right location for me, or is this not really the right fit? Versus waiting until you're at the very end of your pregnancy and then you start to think, I never even realized what some of the common hospital interventions are, and that doesn't really resonate with me and my vision of what a satisfying birth might be for me. So the sooner we have these conversations, the more empowered we will be to have the safest and best birth for us. It was really interesting in COVID to see how there was a big flux of interest in home birth midwifery in New York City. There always has been. Of course, we have the best midwives in the world. Obviously, I'm biased. But it was so interesting because our home birth midwife said, we really can't, this isn't a safe way to choose home birth. You need to choose home birth because that's the space that makes you feel empowered, not because you feel afraid of another option. So this comes from education. So the more we can kind of talk about these things and create more birthing options, I think we're going to see better health outcomes for, expectant and postpartum women in New York City. So we wanted to just touch on, we just have a few more slides if we're going to get to the Q&A, so don't worry. But we wanted to talk a little bit about kind of what is collaborative care, for those of you that aren't really familiar with that phrase. So, in summary, it basically means teamwork, working together in a way where each person in a dynamic is really working at their best and highlighting the skill set that they bring to the team. And so when we're talking about prenatal care and labor and birth, midwives are experts in normal physiologic labor. We're also experts in recognizing when things move outside of normal. And so one of the ways that we can practice at our best is knowing that we have a safety network of support. And that is our OB colleagues and our OB team. So we work with OBs so in New York State, midwives have full practice authority by law. So we are either certified nurse midwives or we are certified midwives, all of whom have a master's in midwifery, and provide independent, care to our patients. We're able to admit you, take care of you, and attend your birth, discharge you, et cetera, et cetera. But in order to function in a healthy, holistic sense of collaborative care, we need to have support from the obstetrical community. And this is something that I think we've really struggled in the midwifery community in the US. When you look at other developed countries in Europe, for example, where midwifery is more this center of the public health system, and more normalized, it's a more natural flow. And so when I heard about Oola building a collaborative care model, I was super excited because I feel like if you can put midwives in the center there, and let them lead that way, we see the research. The research shows that people have more satisfying birth experiences and less need for unnecessary medical interventions. And we have the best of both worlds. So if you have a high risk medical issue, like Ila's right there to jump in and give her expertise, and you may still kind of continue with midwifery care. You get to have like the best of both. For example, we have our scope of practice. So I'm not a surgeon, so that's where you have your OB. They come in. So we work with OBs in a collaborative model through verbal consultation, through co-managing complicated medical cases, and ultimately sometimes transferring care, from midwife hands to the OB hands in cases of needing for a surgical birth, like a C-section or operative vaginal birth, something more complicated. So that's kind of how we work best together, is like use everybody's expertise to be a team. The other team member that we cannot forget is the doula. And I think that doulas are having a renaissance in our country right now, which is super exciting and well earned. They're one of the oldest professions in the world, right along with midwives. You look at the old illustrations of early birth. And it's basically, as a midwife, I spend, 80% of my time when people find out I'm a midwife explaining, are you a doula? So you're a midwife. Is that different than a doula? So we get this question a lot. So we are aligned with the values of doulas in that we all, I don't want to speak for all of us, but we as professions, we work to advocate for satisfying births for our patients, for birth equity, for evidence-based care, and in a non-judgmental and safe space. But doulas are a non-medical role. They provide educational, emotional, and physical support in the pregnancy, birth, and postpartum space. Whereas midwives, while we provide that type of support as well, we are the medical provider in that setting. And so we sometimes have a different hat on that takes us out of that continuous support role. So we work extremely well with doulas. Yes, you can and should have a midwife and a doula. The phrase is kind of that we've always said, like, everybody deserves a midwife. And I truly, truly believe that, and feel so passionate about and hopeful now that Oola is on the horizon with their birthing center, that we can bring a more equitable vision of the midwifery model to more families in New York City. So we're going to jump into Q&A. Thanks so much. I hope it's been informative thus far. Thanks for hanging on with us. And we're going to do a couple of questions here. Let me just pull up my questions from the chat. So Ila, let's start with you. Can you talk a little bit more about kind of how the Oola model is different from the other options that are in the New York City landscape right now, and about kind of how this idea of collaborative care that I've been chattering on about, what that means to you and how you hope to see that work at Oola.
Yes, thank you. So I'm kind of reflecting. Earlier today, I had this conversation with a colleague, a friend about Ula, and she kind of paused and said, "You know what? This is just radical common sense, Ila." And I'm going to just use that term as I describe Ula here because the premise that Ula is built on is really centering the patient's needs. And reflecting as an OBGYN, this is something that the traditional medical system just doesn't do well. It's built within a system where really decision making is often paternalistic. Patients aren't actually part of that process. They're told what to do and they may do it, but they're not actually part of the process. They're not providing the input that they could. And we know, as you pointed out correctly, Casey, that the outcomes around birth and pregnancy outcomes in general in the hospital setting are just not up to par when you compare them to birth centers and midwifery run practices. And so um, when we talk about collaborative care, there are a lot of aspects to it that we described, and the medical collaboration certainly is between the midwife and the obstetrician gynecologist. But for me, really, I just go back to centering the patient. So if we were to sort of think of a diagram, it's the patient at the center. Then we have this tight care team, and there's a collaborative space right here as well, just like you pointed out. The midwife is the true expert in delivering care, and the obstetrician is there to back them up should there be supplemental care. And the collaboration there should be tight and there's a great relationship that we have like between our midwives and our obstetricians, and that's so important because the last thing we want a patient to feel like is if their care is passed or is in tandem with the obstetrician and a midwife, they haven't done anything wrong. We don't want folks to feel like if there is a need for supplemental care that in some way shape or form that their pregnancy journey has failed them in any way shape or form. And so the collaboration along the entire way. The other piece I just want to highlight, I don't want to take up too much space, that's really different about Oola is the ongoing decision making. So I keep talking about centering the patient. A lot of people say this, but how are we actually doing it? It is a different approach to the actual prenatal care setup. So instead of waiting, for example, till the third trimester to start talking about breastfeeding, there are key decision points and topics that we want to engage in with our birthing person along the entire pregnancy journey. Often people get to that space of birthing and they say, well, what if something goes wrong? What if I feel pressured in that moment to make a decision? What if I end up with an unnecessary intervention? Those are all very real concerns, quite honestly. But we want to be talking about all of the decision-making points in concert, led by the patient along the way. That way, when we get to a space where the patient says, you know what, maybe I do want X, Y, and Z, or this is going really well, but I would like, ABC. There's information that's already been shared along the way. And that information sharing, again, I want to stress how important this is a two-way street. And that's where our technology comes in as well with gathering information from the patient and having an ongoing dialogue. So that's sort of where I see things being different. The collaboration is in many different spaces. It's with the midwife and the OB. It's between the patient and their care delivery team, and it's two-way. That's so important to highlight. And there's technology, there's phone, there's in-person visits. There's a whole host of options to really design the care that best fits for the patients. Somebody might love virtual visits. Somebody else, it just might not be the right fit for them. I could keep going on and on, but I'm very excited about that. I will stop
It's
talking.
awesome.
Allow
No,
more
thanks
questions.
for sharing.
Yeah.
Okay, so we have a great question from the audience. So this is for you, Katie. So what happens if you choose a birth center, but then during labor you need a C-section or other complications? And similarly, like what happens if my pregnancy starts off as low risk and then I become higher risk? Like what collaborative partnerships are integral to this sort of care?
Right. So I think actually you said it so well, Casey, when you were talking about the that idea that we're experts at physiologic birth and also experts at recognizing when things start to fall out of our scope. So, to me, the beauty of collaborative practice is not only having those moments where all things are going well and I can just sort of be talking to Ila about a patient's situation so that I have a sense of like, let me just get another pair of eyes, let me get another brain on this moment, on what's going on with this patient. But also that there might be times when we're really standing shoulder to shoulder and actively co-managing the patient, or that there may be times when it's time to hand it off. And certainly the idea of an out of hospital birth center space, I think that fear of like, what happens if I, need to go to the hospital because something's going wrong, or if I decide that I want to go to the hospital because I want to have an epidural instead of the unmedicated birth that I had imagined and planned for. All of that is on the table. We think about transferring patients from the birth center to the hospital. And I think the beauty of the Oola model is that we will be a functional team in both spaces. So we can attend births in the out of hospital setting and also, follow those patients and continue to be part of their care team inside the hospital as well. So that to me is like that kind of continuity of care is what's most important to me.
Absolutely. That's awesome. Okay, so I have a question for Ila. So you've mentioned that an ULA goal is to reduce unnecessary medicalization. Can you just elaborate on that and explain what that really means in your words?
Sure. Yeah. When we look at some hard medical outcomes, such as C-sections, episiotomies, unnecessary inductions, et cetera, we find that we have a lot of work to do in that space. And this goes back to something I said earlier, which is that the traditional model of care right now really is centered within a medical system that prioritizes the provider and also is quite paternalistic in the way that decisions are made. And this all leads to outcomes in which truly the patient's not, we hear time and time again, I didn't feel heard. I mean, I can say even, raise my hand and say, I didn't feel heard during my pregnancies. Decision making is not involving the patient. And what ends up happening is that there often are unnecessary medical interventions, like the ones that I mentioned. And there's a lot of good data and literature out in the world that shows that when you start with a midwifery model, and that is centering the patient is more holistic, brings the patient into the decision making process, that you actually have better outcomes both for the birthing person and the infant. And that's essentially what I'm talking about in terms of reducing those negative outcomes. One other thing I just want to throw on, because Katie has such a beautiful response, is in that collaborative practice. I just want to say, as the medical director, we are centering patient safety. So yes, we are here to provide the utmost flexibility with the highest quality of care. And that's for us to help provide to you, and it's on us to gain your trust that that's what we're here to do for you.
Great. Can we talk for a second a little bit about epidurals? Because that's always hot topic. So Katie, this one's for you. What happens if things change and someone's in labor and they decide, I'm no longer working with my labor toolkit here. I want to transition to pain relief. Can I still have a midwife in that situation? And how do you support that process?
Absolutely. I think, again, you said it, things change. People can go into the pregnancy experience, the birth experience, the parenting experience with the greatest laid plans. And at some point, as I like to say, you just have to get into the river and trust that you've got the right team behind you to help carry you along. I think the thing that's important for us to remember is that our care and the care that we are providing is really non-judgmental. So if you want an epidural, great. If you don't want an epidural, great. We're here for you, really, whatever you decide. I think it's also important to acknowledge that there are times when I, as the midwife, might recommend an epidural. Casey, I'm sure in your practice, you had moments where you felt like someone might really benefit from the relaxation that an epidural can provide. So there are those times where, even though, I might be the crunchy provider in the room, I'm still gonna occasionally recommend medical interventions that I think may have therapeutic value.
Awesome. Okay, I have one for Ila. So we're getting a bunch of questions in the chat about the current state of birth centers in New York State in general. And I know that you guys you have announced that you're opening your prenatal clinic very soon. But will Oola be opening a birth center in New York, or even beyond New York City? Inquiring minds want to know. So everybody's very curious. I'm sure there's more than a few birth workers on here wondering what the
Yeah.
plan is.
Yeah, no, great question. So Ula is starting with our first prenatal clinic in Brooklyn, early 2021. So please look out for that in Brooklyn Heights. And to start, we will be delivering in a very high quality hospital setting as we build out a birthing center. Very exciting. It's coming soon. And we'll definitely provide more information as it comes to fruition, but we're actively building out a birthing center. And honestly, we hope to have many more clinics scattered across all of New York and beyond, um, as long as we do a good job and there's demand. And that's what we're here to do, is to set a new standard in care.
Awesome. Okay, so I have a question for you, Katie. So today is the day. This is launch event. Exciting! It's 11/11. It's an auspicious Wednesday. It's a good day to launch stuff. And you guys are launching your 2 virtual coaching visits today. So can you kind of talk through just briefly about the difference in the 2 visits, and anything that would be covered in them that we didn't talk about in detail today?
Sure. So, yeah, we basically are launching two types of visits. One I talked a little bit about, which is that preconception counseling visit. And then the other would be an early pregnancy visit, which you alluded to, Casey. The sort of window that we're imagining for the early prenatal visit is like between the time that you get the positive pregnancy test and the window of time when you are likely to get a initial prenatal visit, which is usually around like 8-ish, 10 weeks pregnant. So that, month or 6 weeks can really be a harrowing time when people feel a little bit adrift. And we really want to fill that gap. So the idea of these virtual coaching visits is that they will be, focused on what each individual patient really wants and needs. Of course, we have some basic, um, talking points and educational points that we want to get through, but we really also want to hear about what the birthing person wants and needs from us, so that we can really make a targeted approach. So, yes, we will talk about a lot of the topics that we touched on here today, but in a way that's very specific to the person in the room.
Great. So, okay, I want to definitely make sure we talk about a more serious topic that's super important, and relevant right now, in New York City, and um, that is inequities in maternal health outcomes, specifically for Black mothers. So I was wondering, Ila, if you could talk a little bit about how Oola plans to address those health inequities, in your care plan.
Sure. So I think it's not news to any of us on this event that Black birthing people have a 3 to 4 times increased death rates, maternal mortality rates compared to white people in this nation. But what struck me, and may not be new to you, but struck me for sure as I entered this space more, is that in New York, that number goes up to 12 times in New York. And this is actually exactly why we chose New York as our first market to launch Oola. There are many things that we are doing to center birth equity as we move forward. One is what we've talked about here at nauseam, which is very important, is centering the midwifery model and the collaborative care model. There are a couple sort of subpoints to that, which is that the model really is designed to look at the holistic person. It's designed to listen to the birthing person, which is one of the cornerstones that we continuously drop, especially for people of color and Black people. We don't listen to people. We don't trust Black people in a way that we should be, and their care gets compromised. Um, the third piece, I want to talk about Oola in itself a little bit. We are committed to definitely hiring a diverse team, and beyond that, a team that is committed to ongoing iteration and learning around birth and health equity. We have developed anti-racist policies and materials. And as we enter the journey and enter the birth equity space, we recognize that we are new to this space. We're entering with humility. We're entering to build allyships, and we're entering really with our ears wide open and want to learn from the communities around us. So I just want to put out there that this is sort of the cornerstone. You know, Oola was founded around this patient-centered approach. Um, it just exactly it takes steps towards decreasing the disparities in healthcare for Black mothers and people of color.
Thank you. Um, okay. Another important topic is how do things get paid for, right? That is a huge issue in health equity as well. So does Oola take insurance? Do you guys accept Medicaid? That's something that people are very curious about.
Yeah, I can take this one.
Katie, yeah,
I,
sure.
yeah, I just saw it pop up in the chat. That is yes. The short answer is yes. I always say that I think that midwifery care really sort of exists in three strata in New York City. And I think about my own experience when I was pregnant. I was at that point a labor and delivery nurse. I had amazing union benefits that allowed me to really see whatever provider, like I had better out of network benefits than most people have in network benefits. So I was able to see a midwife who had a very small boutique practice, and I essentially paid nothing out of pocket for that level of care. Um, but I think that's not always achievable for people who have more traditional commercial insurance. So Oola is really looking to fill that gap. We're going to be taking Medicaid. We're going to be taking all major commercial insurance plans with the intention that we know that boutique midwifery care is not affordable for the great, the majority of the people in the world, and so we want to make that level of care accessible via traditional insurance.
Awesome. Okay, and we are almost out of time here because we value your time so much. We want to wrap up in a timely fashion so everyone can get on to their evenings. But our last question is for Ila, and this is about COVID. So everybody's wondering how COVID is going to affect prenatal care and birth care. So can you talk a little bit about how Ula is approaching that?
Yeah, I mean, this global pandemic has been unreal on many levels and has certainly really had an impact on healthcare in many spectrums. And we've been really pushed, and it's probably been actually a blessing in disguise that we've been pushed to really look at our clinical protocols. I'm going to talk about the clinical side for just a second, and remove barriers. So there were a lot of things that were being asked of birthing people to do during their prenatal care visits that are actually not medically or evidence-based necessary in any way, shape, or form. And so we're removing some of those touch points, such as unnecessary medical tests, and also allowing for folks to convert certain appointments to virtual visits as much as possible so that they can decrease their exposure to leaving their homes, intersecting with COVID. Certainly from the clinical screening standpoint, we have some strict policies in place. As you know, most people have seen going out into the world, temperature taking and symptomology checking, et cetera. But I think what we've really done here with the model is allowed for maximum flexibility with, again, everything is shaped around patient safety at the core as well. So maximum flexibility in order to shape the pregnancy experience, the interaction with the Oola team in a way that best serves the patient, whether that's virtual or that's in person. But we've had a real opportunity to take a whole new look at it and make it fresh. Things like virtual visits and remote monitoring were just not part of the game prior to COVID. So maybe they'll stick.
Awesome. That is a wrap on our Q&A. I think Ela wanted to say a few words to just say thanks to everybody for coming by, and thanks for having me and Parentcraft. Happy to be here.
No, thank you, Casey. It's been a fabulous event to co-host. Thanks for joining us, Casey at Parentcraft. And thank you, all of you, for joining us to learn more about Oola and Parentcraft. I want to highlight a couple things as we close here. Our virtual appointments are here, they're live. We have a preconception coaching visit as well as our early prenatal coaching visit, both of which Katie talked about in some detail. As participants of this event, you get a 50% off code, planning 50. You just have to enter that in, 50% off on either one of these visits. And I also want to highlight some amazing opportunities at Parentcraft. There's a new breastfeeding and newborn support group that's launching next week. And Parentcraft has a wealth of amazing labor, birth, fourth trimester classes. I actually really wish I had a fourth trimester class when I had my children. That is just something that's so needed. So again, please take a look at our virtual appointments on the Oola side and the upcoming breastfeeding and newborn support group, and labor classes and birth classes on the Parentcraft side. I know we're over, but I just want everyone to know if anybody has more questions, we're here to answer them for Oola, hello@oolahealth.com. Follow us on Instagram as well if you'd like. And for Parentcraft, info@parentcraft.org. And you can follow them as well on Instagram. And I just want to say another heartfelt thank you for letting us share. And please look out for more events. Ila will be hosting another one in the next month or so. Thanks, everyone.